So just a couple of comments before we open it up for questions, and a little bit about our recommendations. I think one of the things I wanted to point out is that, Connie brought up an interesting question about is it supply or is it distribution, or is it both? And it's both. So nationally, we're looking at a shortage of 90,000 physicians by 2025. And what I want to impress upon you is that if you don't deal with that national level and regional level shortages, you will always have difficulty recruiting at the local level. So it's not either or, it's both and. And so when we look at this, there's a lot of different responses. One is certainly looking at how we train more physicians, and we recommended an increase in the overall caps that Medicare has put in for the last 18 years. It's distribution, looking at loan repayment, looking at Title VII, NHSC, J1s. We know that we should be taking better advantage of the fact that critical access hospitals have no cap. How can we get them to train some more physicians? And they're paid at cost. We know that rural hospitals have set their cap at 130% of where they were in 1996. So there's an opportunity there. And we've certainly used some of these opportunities. Redistribution in the MMA of 2003 looked not only at underserved areas, but also unique subspecialties within the state. So if you're establishing a new program where you haven't trained anybody in that specialty before, that's a unique opportunity. So we're doing all these things, but we need to be mindful that we have to do things both at the national level as well as figuring out how to do things like the primary care office or like our academic institutions are doing. And we need to do that while increasing that cap. We also need to figure out how to use other health professionals, as have been mentioned, how to use them in teams, figure out what we do with technology. I'm sorry that Liz wasn't able to be here today, but places like University of Mississippi are providing telehealth services for subspecialties all over the state. How can they do that? There's some other policies that you can act. For instance, Mississippi passed a law saying that telemedicine or virtual services had to be paid at the same rate that in-person services were being paid. That allowed them to really ramp that up. Project Echo in New Mexico is another great example of providing that subspecialty care locally. So we need to be doing all these things, and I wouldn't be doing my job if I didn't mention that last week we had bills introduced in the House and Senate. Congresswoman Castor is working on another bill that we hope to get introduced in the coming weeks, but it's 2124 and 1148 in the Senate that would actually just expand Medicare support by 3,000 additional physicians a year. So kind of a drop in the bucket compared to the shortage, but we think it's an important place to start. The other important thing I just wanted to point out is that, again, not looking at an either-or solution here. You can't look at the way slots are distributed or money is distributed across the country to support physician training and say, well, we just need to move them from here to here and then everything will be fine. I showed you that there are some physician donators, some physician acceptors across the country. And if you just talk about moving stuff around, it doesn't necessarily make good policy, right? Because you've got to look at what the strengths are of the institutions, where you can concentrate your habits. So I have a friend who says, well, look at New York and Michigan and Ohio, and in some cases Texas, and how many people they're training. We just need to move them somewhere else. And so I said, well, let me think about where I get my corn from. And some places have the ability to do things that other places don't. And so if I look at where the corn subsidies go, I can't just say, well, if I move those over to California, and you should grow more corn in Texas and in Georgia, then we'd be fine. So the other challenge here is, as you think about how do you as policymakers aid in not only supporting the programs that work, but the creation of new programs, we have to realize that, as Shelley pointed out, that it's difficult to recruit faculty, and the faculty themselves or potential faculty are concerned about their own skills. How do we actually put some resources in to help them get up to speed? So there's the educational pipeline that's also an opportunity. Again, I can't do anything at the residency level to sort of suddenly shape where somebody goes without thinking about where they went to high school and where they grew up, because it's not just, can I get somebody to marry someone if I go send them to the community? Best predictor of getting somebody into a rural community is they're from a rural community and their spouse better be from a rural community, right? Those are all important things. While we had some success in the time that we can take to establish caps on new hospitals, 5 years is still a short time if you're going to run a general surgery program. So if we could lift that, expand that time frame a little bit, I think we'd get more teaching hospitals, new teaching hospitals on board. And again, as I mentioned, other challenges. So let's take a couple of minutes, and if you have any questions or comments for my experts here, happy to take them.
I might, does this work? I might add to what Atul's saying is that the 5-year, although great as it did expand from 3, but the way the accreditation works is that you need several different types of programs many times before you can add the general surgery or the obstetrical program. And so it doesn't give a hospital the chance to get up to the 400 or 500 residents that we have at many of our big hospitals now. You see, so in my mind, I don't think any of these new hospitals in Georgia will really max much above 1 to 150 because the 5 years still does cut you short. So once you're up and you want to add, say you need cardiology in that region, you know, you've got, your window's already closed. So yes, we can always accredit new, just like the current hospitals are doing, but there's no additional Medicare funding coming. So the 3 to 5 was good, but I can tell you with boots on the ground living this every day, that's not probably going to be enough to have the capacity that we're really trying to gain. You know, when I analyzed all these 170 hospitals in Georgia, there's only 30 that really can do a high quality program. As Atul said, not every hospital is equipped to have a training program. I mean, that's it at the end of the day. But the ones that can, that are in the rural underserved areas, we need to support as much as we can. And those startup dollars are substantial. I mean, if there's anything else that can be done on the national level for that, that would be great.
Anybody think of a question? Yes, ma'am.
Taylor Grozy with the American Medical Association. So I love all these expansion and incentive programs that the two of you talked about. But my question is, how do you incentivize states and communities to make that $2 to $8 million first investment, or even something smaller than that for any of these?
Yeah, for Georgia, it wasn't probably a little bit easier battle because, as I said, our statistics were so low and we're very rural. And so we made the case very early on. And our APECs have been very critical in this. I mean, they've been a huge component of this. And Denise Cornehayes, our executive director, has been very active in the legislature advocating. And I think the House this year put together through a bill, a House study like Med Ed committee, where they then went around the state, and we all testified throughout the state, Emory, all the other experts, so that the representatives could learn more about this. So I think the more you can do and educate, it was completely eye-opening, the stuff that we were doing. They just had no concept of the crisis that we're really in. And I think once they see that and get a handle on it, as I said, the time frame's too long to get to a doctor. So my case was, we've got to start here and now. We cannot wait 5, 7, 8 years and wait for something else to happen. Do you see? Because we were already up against the wall. So I don't know.
We have been successful in expanding our loan repayment programs in large part due to our associations and our partners, both with the Medical Association and with the Health Center Association. When we went through the budget crunch of 2011, we lost funding for our loan repayment programs, but that was one of the first programs to come back when the economy picked up. And that was because we were recognizing that we were losing doctors to go to other states at a time when, you know, our population was increasing.
Yes, sir.
Hi, Charlie Arnold with Senator Warner's office. Was wondering, you just touched on this, but if you could talk a little bit more about the role of non-physician providers in some of these teenage issues.
Yeah, I think what we're finding, and we just did a new set of workforce projections last month, and really tried to say how much could we push the envelope if there were patients that could be seen by other providers, whether they're social workers, pharmacists, nurse practitioners, PAs. Part of what we see is that you can get some level of collaborative care in there where low acuity patients can be seen. The challenge is with the growing aging population, where you've got a 46% expansion of people over the age of 65 over the next decade. Those patients become more complex, not less complex, and so that becomes a challenge. We modeled out the use of retail clinics and found that it could not put a significant dent in the physician shortage. The biggest thing that we could do is actually in addition to training more physicians, convince physicians to retire later. And to get millennials to work as many hours as Marcus Welby did. But I don't know if that's going to happen. So there's certainly a role for them, and they're picking up the slack, but there is a lot of older, complex patients coming, and we kind of need all hands on deck. I want to be respectful of your time. I think we have a couple minutes if people want to come up and ask any questions in depth. If your boss has not joined the Congressional Academic Medicine Caucus, I'd certainly encourage you to reach out to Elizabeth or to John to do that. So thank you again to my great experts here. Thanks for your time.